You know that feeling. It's the one that just stops you dead in your tracks. A sudden pressure, maybe a sharp stab, or just this deep ache right in your chest. It is, without a doubt, one of the most common and, frankly, terrifying symptoms anyone can have. So let's get into it. Let's try to turn some of that fear into real understanding. Right? This is the question that just explodes in your mind. Is this it? Is this a heart attack? Or is it just really bad heartburn? Is this something I need to worry about? Honestly, the not knowing is often the worst part. But what if you had a kind of mental framework to start making sense of what your body might be trying to tell you? And this, right here, is the single most important idea to get your head around. Chest pain isn't the final answer. It's the first clue in a huge medical mystery. Think of it as a signal, one that kicks off this whole logical investigation to figure out what's really going on underneath. Okay, so to solve any mystery, your first step is to decode the signal, right? Well, your body has different kinds of alarm systems, and they all produce very different kinds of pain. Understanding the difference between them is like learning the language your own nerves are speaking. So first up, you've got what's called visceral pain. The best way to think about this is like crossed wires. The nerves coming from your internal organs, like your heart, they all plug into this shared switchboard in your spinal cord. So when a pain signal comes from the heart, the brain can get confused and think it's also coming from the jaw or the arm. That's why this pain feels so vague and deep. It's a poorly localized, kind of confusing warning shot. Now on the complete flip side, you have somatic pain. This is totally different. This is coming from the frame of your body, your skin, your muscles, your ribs. These nerve pathways are like a direct private line to the brain. There's no confusion. That's why this pain is sharp, it's easy to locate, and, this is key, you can often make it worse just by pressing on the area. So let's just put it all together. This is the crucial distinction. Is the pain a vague, deep pressure that kind of seems to be spreading? Well, that's a visceral clue. Or is it a sharp, specific ache that you can point to with one finger? That's a somatic clue. This right here, this comparison, this is our decoder ring. This is what we're going to use to investigate our whole list of suspects. Now, with any investigation, you always start with the most serious possibilities first. In medicine, that means starting at the top of the diagnostic funnel. You look at the life-threatening causes that you absolutely positively cannot afford to miss. And that means we're starting with the heart. And at the very top of that list is the suspect that everyone fears the most, a myocardial infarction. We all know it as a heart attack, and it happens when a blockage just suddenly chokes off the blood flow to the heart muscle itself. A heart attack is the absolute classic example of that deep, visceral pain we were talking about. The profile is so distinct. You've got that pressure, that famous elephant on the chest feeling. It's usually central and it often radiates. But look at that key feature, time. Simple chest pain or angina might last a few minutes, but heart attack pain, it typically goes on for more than 20 minutes and it brings friends, like sweating, nausea, or feeling out of breath. All right, our next cardiac suspect is a bit of a curveball. It's called acute pericarditis. This is when the sac surrounding the heart gets inflamed. So it's still a heart problem for sure, but the pain it causes has a very, very different personality. And you can see that personality right here. The pain is often sharp, not that heavy pressure. But here is the game-changing clue. It's positional. If the pain gets way worse when you lie down, but feels a lot better when you sit up and lean forward, that is a massive clue pointing towards pericarditis. It's a trick a heart attack almost never pulls. Okay, so once the immediate life-threatening heart stuff is on the table, the investigation starts to widen. You see, a lot of other things inside your chest can cause pain that feels deceptively serious. So let's look at the next lineup of suspects. Your esophagus, the tube that carries food to your stomach, runs right behind your heart. Because of that location, it is an absolute master mimic. Things like acid reflux or even muscle spasms in the esophagus can create a pain that feels almost identical to a heart attack. So how in the world do you tell this mimic apart from the real deal? Well, the clues are all about context. It's all about when it happens. Does the pain tend to show up after a big meal? Does lying down make it worse? Because, gravity isn't helping keep that stomach acid down. These little details, the timing, the burning feeling, maybe a sour taste, they all start to point the investigation away from the heart and towards the digestive tract. Next on the list is pleuritis. This is just inflammation of the pleura, which is the super delicate lining that surrounds your lungs. And when it gets inflamed, it can cause a very sharp, very memorable kind of chest pain. The absolute dead giveaway for this one is its direct link to breathing. See, when that lung lining is inflamed, the two layers rub against each other with every single breath instead of just gliding smoothly. And that friction creates a sharp, almost knife-like pain. It's why taking a deep breath, or coughing, or even sneezing can feel just agonizing. It's a huge clue that the problem is rooted in the lungs. And finally, we come to the chest wall itself. Sometimes the source of the pain is as simple as inflamed cartilage where your ribs connect. That's called costochondritis. Or maybe just a strained muscle from a really bad cough or a new workout. Remember that sharp, specific, somatic pain we talked about way back at the beginning? This is its classic performance. The pain is localized, it's easy to point to, but the ultimate clue, the one that really separates it from anything going on inside, is that it's reproducible. If you can press on a spot on your chest and say, yep, that's it, that's the pain, you're actually triggering the source directly. That is something you just can't do with your heart, making it a powerful sign that the problem is in the chest wall itself. So we've got all these suspects, we've got all these different clues. How does a doctor actually put all of this together to solve the case without getting lost? Well, they don't guess. They use a systematic roadmap. And this is how it all funnels down logically. Step 1 is always about safety. You rule out the scariest stuff, like a heart attack first. Then, in step 2, the doctor listens to your story to categorize the pain, using the exact same clues we've been talking about. Step 3 adds that crucial context, your own personal risk factors. I mean, the same story means something very different in a 20-year-old athlete than it does in a 65-year-old smoker. Then, the physical exam adds more data, before finally, specific tests like an ECG are used, not to start the investigation, but to confirm the hypothesis that's been built from all the previous steps. And that's really the whole journey, isn't it? We've managed to go from this single, terrifying symptom to a structured, logical puzzle that actually has a clear set of rules. By understanding the different types of pain and the classic profiles of the main suspects, you can start to transform that initial panic into a much more focused way of thinking about what might be going on. Which leaves us with one last thought. When you look at that whole diagnostic roadmap, what do you think is the single most valuable piece of the puzzle? It's your story. A clear, precise description of what your pain actually feels like, using the very language we've just explored, is the most powerful tool you can possibly give a doctor to help them solve it.